Peripheral nerve examination of the ulnar nerve. First, bedside manner. The examiner should wash their hands and introduce themselves to the patient. Explain the examination that will be conducted to the patient. Then position the patient's hands on a pillow.
Hi, my name is Arifata Zakia, fourth year medical student. Today I would like to perform hand examination on you. Is that okay?
An adequate exposure is important. The examiner should expose the patient's hands up until the shoulder. The examiner should stand at the right of the patient or sit in front of the patient while examining the patient's hand. Next is look. Look at the arm for any deformity. Look for the ulnar claw hand and Wartenberg sign. Note that the higher the lesion, the lesser the claw deformity. This is known as the ulnar claw paradox. Next is the muscle wasting. Look for any hypotenuse muscle wasting and dorsal guttering. This may suggest a lower lesion. Look also for the muscle wasting at the volar forearm that may suggest a higher ulnar nerve lesion. Next is the scar. Look for any scars along the medial wrist, medial volar hand, elbow, medial condyle, and the medial forearm. Then, do a screening test by first asking the patient to flex all their fingers to see for any Benedict sign. Next, ask the patient to extend their finger to look for the claw hands. Lastly, show and instruct the patient to do the OK sign.
Now we move on to feel. The examiner should ask the patient for any pain or tenderness before touching the patient. Now we feel for every joint. We start from the distal interphalangeal joint, proximal interphalangeal joint, metacarpal phalangeal joint, and the wrist joint. After feel, continue to move. Next, the examiner will hold the patient's little fingers to extend the finger to immobilize the metacarpal phalangeal joint and the interphalangeal joint of the little fingers. Then, ask the patient if they could move their distal interphalangeal joint of the ring fingers to access the flexor digitorum profundus. A high lesion of the ulnar nerve will cause a weak flexor digitorum profundus that function to flex the distal interphalangeal joint, causing the patient to be unable to flex the distal interphalangeal joint.
Next, ask the patient to abduct their little finger while the examiner apply resistance against the little finger. This is to assess the power of the abductor digiti minimi. To assess the power of flexor carpi ulnaris, instruct the patient to flex their wrist while the examiner will apply a resistance against the flexion. The palmar interossei power is assessed by instructing the patient to abduct the fingers together and the examiner place a piece of paper between the fingers. Ask the patient to hold the paper as tight as possible as the examiner tries to pull the paper out. The examiner will instruct the patient to hold a paper between their thumb and index finger. The examiner will then attempt to pull the paper from the patient. A positive test is seen when there is a hyperflexion of the interphalangeal joint of the thumb while attempting a lateral pinch, which means a weakness of the adductor pollicis. The examiner should locate the patient's middle epicondyle and gently tap over the medial epicondyle area. Ask the patient if they feel any pain or tingling sensation upon tapping on the area.
Now move to sensory test. Test the sensory at the palmar region of the little fingers. if loss of sensation over here may suggest a lower lesion.
The examiner will end the examination by thanking the patient and washing their hands. End the examination by checking the joints above, below, other peripheral nerve examination, and complete upper limb neurological examination. To make a diagnosis, the diagnosis should include which arm is affected, left or right, is it complete or incomplete, low or high lesion of ulnar nerve injury.